In the November issue of JACC Interventions, there is a great mini focus on radial access. We've done several interviews on the topic. Make sure you look for all of them. I am right now with Dr. Emmanouil Brilakis, MD, PhD, Dallas VA Medical Center, and we're talking about it's a look at radial versus femoral in patients with prior CABG. Why did you look at this particular group of patients first?
So first of all, thanks for the invitation. People with bypass are a little more challenging than the people who don't have bypass because they have bypass grafts, are harder to engage sometimes. So we've observed in our practice when we try to do radial in those patients who had extra difficulty. So we want to do it in a more structured way and try to answer the question, well, is radial working as well as femoral in terms of efficiency and safety in patients with previous coronary bypass?
So how many patients were you looking at?
So we did calculate as a primary endpoint the amount of contrast we use. So we calculated we need about 128 patients to see if the contrast was more increased in one group or another.
Mm-hmm. And in the case of your findings, I mean, this is a tough group to begin with. These weren't really high-risk patients in terms of anything except the fact that they had a history of CABG, correct?
That's right. So in general, when you are having patients with previous bypass, they're high risk to start with. Just the fact that they've had bypass means they're usually older because they had bypass and now bypass is failing. So they're older than the non-bypass group. They have more diabetes. They have more comorbidities. So in general, it's a sicker group of patients to deal with. Having said that, because they're sicker, there is more room for improving outcomes in those high-risk people of patients. That's why we actually selected them for the study.
So what did you find?
So what we found is that people randomized again in two groups. One got radial, one got femoral. The first thing is that those who got randomized to radial, 17% of those crossed over to femoral. Now, that's a much higher crossover rate than other studies. For example, RIVAL was like 7.6. The SAFE PCI that Dr. Rao presented yesterday was 6.1. So it's almost more than double what's reported before. But that's an important thing that to be able to engage well those grafts, you may have to go femoral more often than you would need in non-bypass patients.
Was it spasm? Was it simply you couldn't get there from here? What was the reason?
The main reason was actually that you couldn't engage the bypass graft. So there were some issues with access, but the majority were just couldn't get the catheter fit well enough into the vessel, and that's why we had to use the other access. So apart from that, we found that you needed much more contrast, many more catheters, and you got more radiation compared to with the radial versus the femoral access. So essentially all the efficiency parameters were in favor of femoral, so much faster engagement, fewer catheters, less radiation dose. And moreover, the other factor is that complications were the same, but we're not powered for complications, only 128 patients, so we're not powered to see any difference in the complication rate.
Now, what's interesting is you have some negatives, a tough crowd, so to speak, and yet the patients were really quite happy.
That's an excellent point. So in spite of the lower efficiency in the radial arm, the patients were happier with the radial arm. And that's consistent with everything we know so far. As you know, that always radial people prefer because you can stand up right away. However, they may not have known that if you had gone femoral, you might have been out of the room quite earlier than the amount of time you've been there before that. But I agree that clearly it's more comfortable procedure because at the end you can just get up and walk and you don't have to lay down and have someone hold pressure in the groin.
When you balance the downsides with the fact that the patients are really happy if they can successfully go through a radial procedure, what's your clinical take-home here?
It's an excellent question. So my take-home is that this is not a group of patients that radial is the best approach, I believe, because it becomes a safety issue. If you're going to give more contrast, you're going to give more radiation, use more catheters, causing more spasm, scraping the aorta in those older patients, I don't think it's the ideal approach. So in my mind, again, would have more satisfaction, but in terms of efficiency and actually even safety, I think for this particular group of patients, the femoral approach might be the preferred approach to go.
So don't even tell them about the radial, or would you still say, now this is the option and spell it out for them?
Well, that's more a philosophical question. I guess there's always an option. If the patient requests it, obviously we will do it. But in general, at least in our practice now, we'd rather go straight to femoral and do radials only in the patients who specifically ask for it. And then we explain to them that actually this may require more contrast and more radiation.
And we may have to go through femoral after all, but if that's what you want, we'll start with radial. We'll try that.
That's absolutely right. But again, I think this is a pilot study. We want to emphasize this is a small study. We need to do it in a larger population with many more patients. But especially for people who are urgent, for example, STEMIs or more complex procedures, there's no question that this is not the approach to go. If you have ST elevation MI with the previous bypass, femoral is clearly the way to go since time is muscle in that setting.
Well, as I said, JACC interventions, a mini focus on radial access, and it's really a good issue. It's the November JACC interventions. Please look for that, as well as all the news coverage from TCT at Cardiosource World News. I'm Rick McGuire.